Good afternoon, everyone. This is Lynette Elliott. I am showing that we are at the top of the hour, so we're going to go ahead and get started. We typically start out our meetings with a few administrative items, and that lets everybody get logged in and dialed in if they're not already. If you want to go to the next slide, please. This is a community collaborative, and we've had some wonderful chats in the past weeks, and we ask that any or all of you who have questions or comments post in the chat during the presentation and the discussion, because there are so many other people on these calls who can provide input or feedback to answer questions or to pose other comments or thoughts. And when you send a chat, please send it to everyone so that everyone in the group can see it and not just the host or the administrative team who's running this call behind the scenes. Next slide, please. This is our antitrust practice. As part of the HL7 Fire Accelerator program, we are required to have this particular statement, so we include it at the head of the deck just for your awareness. Next slide, please. If you have not already joined the project as a committed member or as an other interested party, please take a moment to do so. This is how we manage our email outreach and distribution for our calendar invitations. We appreciate you participating in this meeting, and if it's your first time on this call, welcome. We're glad to have you, but please do take a moment to sign up and join the project as either, like I said, an other interested party or a committed member. We have participants of all levels in this project, and all of you are utterly important to the success of this. So we are glad to have you. Next slide, please. These are our sponsors, our project founders, and our in-kind support as of today. These are the people who make this go. So we are very fortunate to have all of this support, and we can't do this without you. If you are interested in being a Gravity Project sponsor, if you'll go to the next slide, please, you can email us at gravityproject@emiadvisors.net, and someone will reach back out. Or there's also a form that you can, it's just a little quick form that you can fill out on our Confluence to express interest in supporting this project financially or with in-kind resources. And again, it takes a village, so we'll be happy to have you join the village. Next slide, please. This is our agenda for today. We have a few quick announcements, and we'll show a project roadmap and upcoming schedule. There are some changes that we'll discuss in that. And then Linda will walk you through the housing domain data concept submission statuses. She tracks all of the submissions and what has been submitted, and she will share that with you. And then Sarah will walk you through a debrief of the HMIS screening adjudication. That group has been doing a lot of work behind the scenes, and she will share that with you. And then we have drafted the EMI team and the Siren team, and the people behind the Gravity Project have collaborated to draft an ICD-10 Diagnoses proposal that Sarah will share with you. And then we'll take some time to discuss goals. We've been through interventions and assessments thus far, and we'll talk about goals. And then we'll go through some community homework and next steps. Next slide, please. The May virtual Connect-a-thon results have been published. There's a report out here on this link. It is on Confluence. It's in the fire section. We do post these presentations online following our meetings, so you don't have to try to desperately scribble this while it's on screen. But we can also, I can also post this in the chat at some point as we go through the meeting if you want to check out the report out for the Gravity results during the Connect-a-thon. Next slide, please. There's also a virtual interoperathon taking place right now as we speak. Some of you or some of your colleagues may be participating in this, and we really appreciate it. But there's some general information available also on Confluence right now, and then the report outs will be made available following the event. We do not have a link for those yet, but we will share it as soon as we get it. Next slide, please. We have stood up a Gravity and COVID-19 collaboration site. Several of you have probably visited this and posted on it. You don't need to have a login in order to view the blog, but if you want to post content, they do require an HL7 Confluence login. There's no charge. You just need to go through the administrative process for requesting a login, and that link is here, and that's through the JIRA site for HL7. Next slide, please. And I will hand it over to Sarah at this point because she'll walk you through where we're headed. Sarah?
Hi, yeah, this is Sarah DeSilva here. So we're going to have some collaborative conversations on many different things today, and the calendar is the first one. So this page is, you're aware of it, right? So this has been what we've been doing since February to now, meeting every other week, and here we are. So we've gone through reviewing housing instability and homelessness concepts. We've discussed dividing our work into two different phases, the housing instability and homelessness phase 1, and then inadequate housing phase 2. We were due to begin the end-to-end review process, which is basically a collective massaging of that data set in the next couple weeks or so. Because of the work on it really has reached a critical mass on the number of people who are coming in right now to help build the interventions framework out. We'll discuss that in a little bit. So we have a suggested path forward, which I'm going to show you on the next slide. Next slide, please. So again, as we've conceptualized it, so the housing insecurity is the global set of concepts, and in it we've divided really into these phase 1 and phase 2. So what we're proposing is basically a week-to-week touch base on the two different concepts, starting with the next meeting. So our next meeting on the books is in a couple weeks. And from now until then, really trying to focus on submitting inadequate housing concepts to build out the already existing inadequate housing data set that we are collecting, because we have been adding inadequate housing concepts, both from our collective screeners that we had carried over from food insecurity and from individual submissions. So there's an existing body of work there already. And then continuing to work on the housing instability and homelessness interventions and diagnosis work until we get to that point where we really feel like we have a collective set. So really doing these two things in kind, starting in the next meeting, in order to make sure that we're keeping on our work in a timely fashion, because we do want to make sure that we wrap up housing insecurity as a global concept over the next couple months. So not to delay starting inadequate housing discussion of the domain the next time we meet, basically the inadequate housing kickoff, which correlates to the housing instability and homelessness kickoff we did earlier in the spring. Next slide, please. One of the questions that I want to put forward to the group, and this is part of what we've discussed in the past, is given the amount of work to be done and the timeline for completing that end-to-end review for housing instability and homelessness and inadequate housing, it may be appropriate to meet weekly in the months going forward to make sure we're staying on a pretty good clip with that work and finishing according to our projected timelines. And just want to see if there's a pulse from the community, if that's something that you all will be willing to do. You can just put little pings in the chat. Have a ping in the chat if it's not something that you feel like you can do, so that we can assume that people might be able to adjust their schedules to attend. In correlation with that, as you all know, I have been doing lots of side work, trying to get focus groups, both with the HMIS, HIT work group, which we'll present on very shortly. Oh, that's nice. Some people are saying yes. Time is tight. Yes, it is indeed. As I was saying, one of the things that we can pair with this, if it really seems like those every other week meetings are the way to go, and we cannot meet weekly, is developing really focused subgroups to focus in on the interventions work, where maybe some of the community would gather and we do a really like deep dive into making sure we have the community representations we need. In order to carry on, Weekly makes sense, but regular time, yes, it would be carved out into the regular time, and we'd have to adjust existing other meetings accordingly. Most notably, probably putting our technical advisory committee on a different schedule after consulting with them as we alternate meetings in the same time frame. All right, so just to be clear, again, in order to stay on a steady clip and understanding that housing insecurity really is a global concept, of which we divided into two different sections: housing instability and homelessness, phase 1, and then inadequate housing, phase 2, and understanding the need to really leverage the final, like the breath that our community partners in housing are suddenly feeling after addressing COVID. There's lots of activity in that space right now of folks wanting to help. So we're going to try to leverage that, build out the data set that really does us our work justice, and then keep going forward. So we'll see you on June 11th for our next meeting. Next slide, please. This is the gravity timeline. Here we are in quarter 2. We updated. The little line moved along. The tandem work really of the fire development work and the domain and terminology work that we do collectively. I do want to state that there's no update on this in a slide, but I can testify that Linda and the Gravity team are working very hard with coding organizations and submitting coding concepts for our food insecurity data set. Linda's put an incredible amount of hours into that work. I assisted with the ICD-10-CM application along with some of our colleagues from AHIMA, Kathy Gianangelo and Donna Rugg, who are on the call. So we continue to make progress with building out the concepts, or at least applying to build out the concepts that we've identified collectively in our community. And we'll have updates about the status of those applications as that comes in. Next slide, please. All right, so this is Linda passing the torch to the wonderful Linda. Are you ready?
I'm ready. Thanks, Sarah. All right, so this is our, oops, let me move this. This is our current status of our submissions. We have 13 submissions. We've reviewed 9 so far, and we've returned 4. And just to let you know, a couple of the ones that we're still in process, we have a couple where we need to reach out to the submitters to clarify or get a little additional information. So we're working on getting that done. But as you can see, we're starting to build in some more information in terms of our, we have a number of screening tools out there, but we're starting to add more, and hopefully we'll be adding more to this in the diagnoses and the goals in the intervention section as Sarah continues to talk about those areas in the next few slides. But the goal right now is to get everything adjudicated and returned to the submitter so you know exactly what the status is of all of the concepts that you sent to us. And as we move into the end-to-end review, and eventually, obviously, when we get to the consensus voting later on after we finish inadequate housing. And just a reminder of the dispositions for those of you who did submit. When you get your file back with the dispositions that you'll see there, this is just a little more definitions about what they mean. Just for information purposes, here are all of our submitters that have sent us terms for consideration, which is great. Thank you to all of these people. And when we finish next couple of days after this call, we will be posting the next version of the master so you can see what's been added since the last time. And this is just a recap of the link where you can go to see the master. You can see the current one, and then you will be able to see the updated one once it's out there in the next couple of days. All right, and I think that is all for me. So turn it back to Sarah for HMIS.
Hi, it's my honor to talk a little bit about the work that the HMIS Health Information Work Group was doing. This was a tiny little group that has been meeting since February, including HMIS vendors, like such as WellSky, HMIS analysts, a colleague of mine from college, to a set of really amazing nurse informaticists and nurse researchers, you know, some colleagues from SAS, and then Matt from Open City. So we collectively mapped the HMIS data sets and then submitted it to Gravity for adjudication, and this is the results of that adjudication and a community conversation. So next slide, please. So one of the things that I just want to approach, but like cover in general before we dive into the conversation, is the way Gravity has adjudicated screening elements in the past. The questions we ask ourselves from a subject matter expert perspective, and here's where I wear a couple hats, right, is does the question lead to an outcome which is either domain yes or domain no? A good example of this is some of the adjudications of data, such as the Cardia screen, which is a financial screen, for strain screen, which is, the questions are how difficult is it for you to pay for food, housing, medications, et cetera, and then you answer a difficult, like not difficult, very difficult, et cetera answer. So that was determined in our food insecurity adjudication work to not be a screen for food insecurity, because you could answer the question and not come up with any outcome that pointed to food insecure yes or food insecure no. So the questions in our screeners need to lead us directly to the domain yes or domain no. If they're cascading questions, the initial question can be the yes or no, and there can be refinements. But really the whole set of concepts needs to be considered as a domain yes or a domain no question and answer. And then one of the things that's come up with as we worked on this HMIS HIT adjudication is the question an operational screen for eligibility or a screen for the question itself? So one of the things that we hit with, and this is why we're bringing it to the community, is the HMIS questions are often screening for eligibility for different programs. And so the question that we need to kind of hem and haw over is whether the questions are these in the moment operational screens for eligibility or screening for the concept. I'm going to say that this is kind of a gray area, which is why we're bringing it to the community, because what you'll see in our diagnoses are the statement of some of the outcomes of concepts that are raised through HMIS questions and answers. So next slide, please. So these are the HMIS data elements in a rough swath. And again, I paraphrase here. So you have the first concept of current living situation. You have concepts of time frame to leaving current living situation if it's less than 14 days. You have whether a next residence is identified, whether there's resources to obtain permanent housing, whether the person had a lease or home ownership in the last 60 days, whether they've moved 2 times in the last 60 days, what their prior living situation was and how long they lived there, whether they were enrolled in permanent or transitional housing for less than 7 days, if their prior habitation was on the streets, in an emergency shelter, or in a safe haven, questions of when you became homeless, how many times you've been homeless, how many cumulative months you've been homeless, and disability status. So if you are an HMIS person, you can understand that many of the latter questions are getting you to the chronic homelessness diagnoses. But when it came time to adjudicate the HMIS data elements with the lens that we've applied to food insecurity in the past, if you look just at the questions, whether you get a housing insecurity, which includes all of those concepts, so not just homelessness. So we have literal homelessness, unstable housing, et cetera. Both of those things would qualify. These are the 4 elements that popped up as being 100% clearly aligned with the concept. So current living situation, that this question mirrors the questions that you see in health screeners such as Prepare, like where are you living now? If you are living on the streets or living in a home, you have a housing insecure yes, housing insecure no outcome. Time frame to leaving current living situation gets that housing instability at risk question. Moving 2 times in the last 60 days, again, it points to housing instability and like multiple moves. And then prior living situation is the same answers as current living situation, but look back as opposed to a present tense. The other questions and answers, it was harder for us to say very clearly that they were like yes and no when it came to the domain. Even like when did you become homeless? That is a refinement of the yes no concept, but it's not going to come up with homeless yes or homeless no. How many times homeless, how many cumulative months, and disability status point you very clearly to the chronic homelessness assessment, but it was difficult for us to say that this was cut and dry concept domain yes or concept domain no. So when it came time to add to the master, the 4 that are in green are the ones we have currently, and this is really a moment to present this to the community and get feedback on thoughts regarding that. Lucy has a question here. Hate to add this long list. One result of COVID is introduction of rent forgiveness and eviction into everyone's housing horizon. Yes, so in a separate screening element, there are many concepts of rent forgiveness, behind on rent, and eviction risk. I don't know how many questions there are in the American Housing Survey, but we do include those concepts absolutely in our current submission, in the current data set and the master through the American Housing Survey questions. Yeah, okay, great. So any thoughts on this predicament where when you look at the HMIS data elements and framed as questions, these are really the 4 that rise to the top as being very clearly aligned with homelessness and housing insecurity from a screening from the domain standpoint. Anybody want to unmute and pipe in, or any concerns regarding this? Yes, makes sense. It's consistent. Look at that. Thanks. And then we have eligibility requirements change. I agree with the intent to get to a domain yes or domain no. And I'm going to be clear. So what I'm really looking for right now is just a general like okay to proceed, because that end-to-end review when we get there is a time to kind of work some of this out more particularly. We did a lot of adding things back in the end-to-end review for food insecurity. So we just want to make sure that this represents the work of the HMIS HIT initiative, and then we can go forward from here. And I do want to state as well, this does not preclude the whole HMIS data element set getting built into LOINC separately. I really feel very strongly that these elements are consistent enough in general that they would be really applicable for being built into LOINC independently. And many of these elements are already included in other areas of the health record, such as disability status. So that comprehensive, not including them in the homelessness or housing insecurity data set does not mean not including them in interoperability methods. It just means for the logical computable model of the FHIR standard in our value set, they're not in right now. Okay, so in the absence sorry, is there a separate set of questions for a screener versus a full intake? Yes. So this is actually a very really appropriate question, because we do include screening elements in this section of the data set development work, but very similarly, like screening for food insecurity versus full assessment for food insecurity with SNAP eligibility, that would then be part of the next set of work. So we can imagine if we did build a full HMIS data set into LOINC, that full assessment could happen in a different phase of the assessment of the person. We're also open to having HMIS folks tell us that this is not the way that we should do it and we should include every single question. We just, this is what we have for right now. Yes, exactly. Yeah. So then Mike's talking about thinking it might be a little bit like summary fields in FHIR resources. And then Courtney Baldridge says, is there any benefit to screening related to a person going in and out of relatives' homes they may identify as a housing? Yes, so there is a benefit, and those concepts are covered in additional screeners. So the master set, I can safely say the screening tab of the housing master list is the most comprehensive. It is very robust. So if you were to download the master and do a search for concepts, you could easily find the concepts related to going in and out of relatives' homes, and that we often call that doubling up. So that's in there in the American Housing Survey. Does context matter? I ask because 3 of the 4 highlighted questions are only asked of individuals under certain circumstances, whereas the other one is asked of everyone. So Sarah, can you unmute yourself and help me understand what you're asking? My guess is no, because as long as it's concept matched, you can use it in whatever settings appropriate, but I think I'd like to understand your question a little bit better.
Sure, I can try to explain. So the first 3 questions are only asked in very specific program types in HMIS, yes. So they're only tied to those. Whereas the 4th question, the prior living situation, is asked for everybody. It's a requirement for everybody. And so data isn't collected in those first 3 questions very often.
Yes, okay, so that's HMIS novice here, understood, but that's why we included both of them, so that you could, so the answers to current living situation and prior living situation are matched, right? So you're able to implement it in whatever program type you'd want to, as long as it's conceptually domain appropriate. Does that help?
I think so, yeah.
Yeah, and if not, if I did a bad job, you can email me after and we can hash it out. I think when we first, I mean, I do understand that the prior living situation is the default. It would just be, we couldn't not include current living situation because it contains similar information. All right, so in the name of time, the answers to, so Rita says, are there more specific questions that speak to a person's living situation, even if only sheltered versus unsheltered? Current living situation seems vague for the first questions. Again, these are just put here in the order. They're not necessarily in a correct order. If you looked at the answers to current living situation, it's pretty robust in the answers to prior living situation. Each of these answers are in the master as it stands right now, and they give a robust amount of information. And then again, there's plenty of other screeners within the housing screener tab that flesh out the similar concept from a manifold of different ways. And it needs to be said, even the American Housing Survey, there's many repetitive questions, because part of what the American Housing Survey is doing right now is testing questions. And so there's multiple questions regarding similar concepts or subdomains within housing insecurity that are there for reference. All right, okay, so for the sake of time, we're gonna proceed on. Next slide, please. And now I'm going to debrief on ICD-10 diagnoses proposal, and just a ton of work that's been going on with subject matter experts trying to understand how to build housing and security concepts into existing ICD-10 taxonomy. Next slide, please. So again, this is the lay of the land, the Z59 set current state. So the whole parent is problems related to housing and economic circumstances. So it contains many of the social risks underneath it. So we have homelessness and inadequate housing that get their own Z code. And then you have discord with neighbors, lodgers and landlords, problems related to living in a residential institution, the old standby, lack of adequate food and safe drinking water, which we tackled in food insecurity. You have poverty codes, insufficient social insurance and welfare support. And then in classic ICD structure, you have 2 additional codes, which is other problems related to housing and economic circumstances, which really stands for something specific that's not related to or stated above. And then the Z59.9 is problem related to housing and economic circumstances unspecified. Again, the Z59.8 and Z59.9 are ICD conventions. So the predicament we have with housing is that there is no general parent for housing in this set. So they've already defined homelessness and inadequate housing, which we've already represented in our early work as being subdomains of housing insecurity. So it's difficult to figure out where to build off the missing concepts. We went through this a whole lot in our last meeting, so there's slides you can pull off the Confluence to look into this. But when we're trying to figure out where to put concepts like at risk for eviction or behind on rent, it gets pretty tricky pretty fast, because we would lose them if we put them in other problems related to housing and economic circumstances, because bankruptcy is also in there. Anything that's specified within this whole set, again, that's not already specified above. So we lose them if we put them in other problems related to housing and economic circumstances. At least we lose the housing specificity, but we have no other place to put them. So we're trying to figure this out. Next slide, please. So one of the ideas specifically regarding homelessness, and this was brought forward by the Children's Health Watch team, was to at least try to build off right now the homelessness Z59.0 ICD, because homelessness has many different kinds of risk. This will be familiar to folks who helped us work on food insecurity. So initially we had a food insecurity ICD code, and then we discussed how to intervene in different risk-based situations and the need to define ICD according to risk to leverage resources. So what Children's Health Watch they really have been working so hard, and I'm so grateful for them, allies in everything of mine. So was the idea of specifying children off of this homelessness code to define, first of all, two general kinds of homelessness, the sheltered and the unsheltered. Certainly unsheltered would be more at risk than sheltered. And then within that, within the children of Z59.01 or Z59.02, specifying chronicity. So you would have chronic unsheltered homelessness as a possible suggestion, and then chronic sheltered homelessness as a possible suggestion. The difficulty is the alternative to chronic blank is still up in the air. There's multiple different terms that we use to define the opposite of chronic. So we'd have to come to agreement on that. And then according to ICD specifications, we'd have to build out the unspecified code as we did in other ICD concepts. So open up for conversation here. Any thoughts on this proposal? So even with definitions, would this be specified as unsheltered versus sheltered in the patient record? Hi, Donna. Do you want to unmute yourself so you can relay that predicament from an AHIMA perspective?
Sure. Hi, Sarah. This is Donna.
Hi.
Having the definition is fine, but the coder can't follow a definition and plug it in either as sheltered or unsheltered. Somewhere in the record, it needs to be documented as unsheltered or sheltered.
Yes. Yeah. And so Donna it was one of our lovely colleagues from AHIMA, so she often represents the coding perspective. So what she's referencing is that the clinician or the person doing the assessment would have to have documented that if the person is either homeless and sheltered or homeless and unsheltered in order for the code to be dropped. Is that what I hear you saying?
Yes, that's it. So I don't know if that's something that is documented or not, because this is not something typically that has been ever captured before, so I don't know if they get down to that detail, but a coder can't follow the definition and then determine which one it is.
Yeah, and the truth is we do get down to this detail. So if we look at the screening questions that we already have submitted and some of the ones that are already built, for example, into LOINC, like prepare, this degree of specificity, like I'm in a shelter versus I sleep on a park bench, those are represented in the screening questions we ask and the assessments we make and the programs we connect individuals to.
Okay, perfect. Thank you.
Yeah. Any other thoughts here? Does it seem like a good approach? Yes. Yeah. So this is a nuance. Yeah. So John Ritter says inability for students to receive school instruction at home due to homelessness or lack of internet access at the temporary sheltering location. Yes, this is definitely a COVID specific concern. One of the things we're going to be figuring out as we address inadequate housing is the difference between utility insecurity and infrastructure. So we might want to have a back and forth about where these concepts sit, but certainly understanding the infrastructure inequities that we're seeing play out in real time all around us right now, this is a really pressing question to answer. Yes, and so Mike says there may be several dimensions to homelessness that could direct other layers of codes, and we probably need to discuss these options. And this is what we can do, right? So part of the reason why we are starting inadequate housing on the 11th and then continuing to refine this set is I think we knew going into it that housing was less conceptually defined than food insecurity. There's a lot of agreement in the food insecurity world. It still took us a long time to come to agreement. So plenty of room to refine this and hem and haw on it as we go forward. And then if we plan to bridge the level of detail needed between housing agencies and the medical practice, ICD may not be the best tool as the base for the map. It's true. So we did not present this time on other options. One of the things we're working on is considering SNOMED and SNOMED mappings. You know, one of the blisses of SNOMED is you can get pretty granular. So you can, within inadequate housing, specify the type of concern that is present in the housing quality, et cetera. Oh yes, the T code presentation. I watched that one. Yeah. So maybe for a different, what we can do is talk about T codes for billing at the next meeting, just because it is timely. And then Mark says shelter can be in the eye of the beholder. Yes, it would have to be defined, and it is defined, but we would have to make it clear. Okay, so this is a proposal, and it seems like I don't sense anyone completely resistant to this idea. So if it's okay, what we can do is, again, proposal is the first step. It becomes something that we collectively hem and haw about, and because if it's not on the master to comment on, if it doesn't, we can't really comment on it. So the process of gravity is we need to suggest things and then put them in there and then hem and haw. And again, a lot of that hemming and hawing happens in the end-to-end review space. And you can tell I'm from Vermont because hem and haw is totally a regional statement. All right, so there's a lot in the chat. I haven't been able to catch up on everything, I don't think, but is there any other question before we move on? We have a couple to-dos coming back on T codes, considering yes, and then Donna, absolutely, there would have to be other and unspecified if we went forward with this because of ICD conventions. Exactly. Okay. I think I've covered everything. Again, because of time, I want to make sure we're staying on time. And again, any other follow-up questions, you can always email me. You can always email anyone in the Gravity team. The next step is for this to get put into the master as a proposal, and then for us to collectively figure out how to represent it best. Next slide, please. Oh, this is just a little word map I made about everything that's left. So there is a lot left, and so this to be determined. And I wrote Donna Pickett at the CDC National Center for Healthcare Statistics trying to figure out how to solve the problem, because really part of the complexity is we have a lot of things we want left that we want to say specifically, and the current structure of Z59 doesn't give us a very clear parent to build off of. So I need to sit with Donna Pickett at the CDC again and keep on figuring this out. So until then, this lovely little word cloud exists as what we're working on. And again, this is part of the reason why we felt like starting inadequate housing and continuing the work of housing insecurity and homelessness was really pressing, because we really want to make sure we get this right. And yes, Donna Pickett still, hello, yes?
Sarah, this is the best parking lot representation I've ever seen.
Aw, this is what happens when you make slides late at night.
Keep doing it. Keep doing it. We're all benefiting.
All right. Yeah. And Donna and I have lots of really interesting conversations. Donna Pickett is still there. She's great. Okay. So next slide, please. Okay. Any questions? I think we've been doing a fairly good job actually running the chat as we try to address any questions. Anything left? No. Okay. So next slide, please. Debrief, goals. This is really quick. If we go to the next slide, you can see it has two things, because there's only two things. So currently, as it stands right now, the goal section is pretty slim. So we, again, are building this out as we go. But if we think about, again, what was in food insecurity, and you're always welcome to go and download the food security master from the Confluence and look at what we've done in the past. But if we looked at the past, we had food security as a goal. And then we had all of these decrease in prevalence and severity concepts. And then we had access, food security, food resources as a patient-derived goal. So as we stated in the beginning with setting the stage for the screening questions, there really is no gold standard universal tool for housing security. There's no HUD tool. The American Housing Survey is that in process, but that's not set to be refined and completed for many, many years now. So because of that, the severity within housing security as a general concept is difficult to assess. But what we could imagine if folks suggested them was specific concepts regarding connecting a homeless individual, unsheltered homeless individual, to shelter, or specific interventions for types of housing insecurity, like addressing housing quality concerns. And here I am, classic fashion, suggesting things that I might just go put on the subject matter expert submission, but we really want to spark curiosity from the community. If this is all we have now, there really is a lot of room for folks to keep on building. So please send us an email if you have ideas. We did put on the working master for the subject matter experts all the ideas from the chat last time. So know that every email you send, we digest and then go forward. Any specific comments on goals that we could possibly include besides the things I just threw out? Or you can just send an email. Goals are tricky, but important.
I think it's really good to have very simple, easily communicated goals. Mm-hmm. And that's what we have here.
Yeah.
Ultimately, when this group is finished with all the incredible detail that we have to go through, this all needs to be communicated to the outside world. Yeah. And when talking about housing, it seems to me these two goals, that is, these two phrases and concepts, are easily grasped. And then people can say, well, what do you actually mean by this? And then there'll be pages and pages of detail. But yeah. These are talking points, and I think that's essential, because there's so many people who have never thought about this, and I certainly haven't thought about this in this level of detail ever.
Yeah, I know none of us have. I know it's so the only thing I'm thinking as we're talking though is it may be wise to do goals related to the phases of housing of our work, right? So if we've differentiated housing instability and homelessness from inadequate housing because we know the interventions are quite different, and I actually think this exactly addressed what Matt was saying in the comment, it might be wise to access housing resources as one and then address housing quality concerns as another, right? So if it's possible that in the simplicity we haven't represented the two phases of our work as well as we could. So that would only add one other code, but that might be a good thing because then you could track. And so Carrie is agreeing with that. So what I'll do, I'll give us something to chew on next time by putting a concept on the master. So Mike Klinkman says, the danger in overspecifying goals can be in the goals document that CMH has built in some areas with 10 to 15 standard goals before any treatment goals. That creates make work rather than add value to the client engagement process. Heard. As a clinician, heard. So we want to make sure that we're always balancing practicality and specificity. This is the nature of our work. We do try to think about that in everything that we do to make sure that we're not making it harder to take care of people, because the goal is actually to try to make it easier to take care of folks in real time. All right. Okay. Next slide, please. Any questions? I think we already, again, we're working the chat box. Okay, so now next slide. I think we might give people back time, which is amazing. So I just wanted to give an update on community-based organization outreach. You can just go to the next slide. This is just a quick update. We missed okay, so there is a slide. Maybe it's the next slide. Yay, okay, that was supposed to be if you remember, I put out a plea last, I say plea very honestly, last meeting to try in this final slight breath in some areas regarding COVID, use the amazing resources of this community to connect with community-based organizations to ensure we have their perspective in the data set. I think at least 10 people wrote me an email afterwards. I have a host of meetings over the course of the next couple weeks. I am incredibly grateful, and we are as a collective incredibly grateful for the leveraging of this public gathering with folks on the ground. And again, that feeds into part of why we're starting with inadequate housing next, in order to allow that the community to weigh in on what we're creating over the next couple weeks. So thank you just so much for your emails, and I will be talking to many of you soon. And just to catch folks up who might not have been on the last call, understanding that our community-based organizations have been incredibly involved in direct care because of COVID. We wanted to make a pointed effort to try to connect with them now to ensure that we have community representation, because when we compared the housing submissions to the food insecurity submissions, there was a far greater representation of community-based organizations in the food insecurity work. And we hypothesized that it's necessarily because of being preoccupied with the pandemic at hand. So we are doing a little bit of direct engagement and work with our public collaborative, and I'm very, very grateful. So look for this new concept to come through faster soon. And then now is the homework and next steps question. So if you heard me mention the last meeting on the Confluence, because in the last meeting, for example, is when I threw up all the mappings of the ICD codes to SNOMED codes and where they stand right now. So all of our past meeting materials are available on the Gravity Confluence. So if you feel like you need to catch up or revisit something, everything's always there for you to find. Next slide, please. If you want to sign up to join this 2020 September Connect-a-thon, here's the link. We want to make a similar plea. So I made my plea to work with community-based organizations, and you all responded. We just had a pretty lovely Connect-a-thon just the other week, and we really noted the absence of some pretty critical voices in the Connect-a-thon members and participants. So we're specifically looking for that September Connect-a-thon to have representatives from the following members of the health ecosystem: the health records, HIEs, and digital health platforms, community-based services, and referral platforms, and system integrators. And we really want to try to have representation for both clinical and non-clinical participants. If you have any questions on this, then you feel free to contact EMI, and we are 100% here to help you. I mean, the Gravity Project, through the Gravity Project email, which sends to EMI. We also want to try to make sure that we're representing and building our committed members or interested parties. So if you're on the call and you have yet to sign up as a committed member or other party, please do sign up on the Confluence so we can have your contact information. So there's a comment here. So not to throw a wrench into things, but is there perspective on a perspective question that should be asked? For example, many people who are technically homeless in Hawaii don't consider negatives of homelessness as they live on the beach. This doesn't matter as much. Yes, so I think those, yes, you can change your status from other interested party to committed member, but okay, I'm sorry, I'm skipping steps. So I think the thing is so screening questions function as screening questions, but I always try to reference again the Gottlieb and Alderwick taxonomy that they published a little bit ago in the Milbank Quarterly, which is the difference between social risks and social needs, right? So screening is really a risk assessment, right? But a risk assessment does not indicate that the person wants the thing addressed. So even if you do like a PHQ-9 to screen for depression, it's a risk for the condition. It's not the presence of the condition, and the risk means you have to dig further. So we conceptualize the screening element as really the risk, and then the interview and the conversation with the person and the assessment of priorities and identifying the need. We try to lace that through our approach. I think this is partly why we give weight in our work to the separation between screening questions and diagnoses and assessment. You know, that's a clinical point that I try to make on a regular basis. So I think, yes, that perspective is part of how we consider pretty much everything we do through the Gravity Project. If you have ideas about how to do it better, we are always looking forward for those ideas. But that's definitely part of how we've structured the data organization and the master to this date. And again, if anyone's interested in that lovely paper, I can try to send it around to the community. All right.
Sarah, last time when you were asking for EHR and HIE participation in the September Connect-a-thon, I offered the possibility of a brief presentation to one or more direct trust committees.
Yeah.
I haven't heard back about that. Is there something more I should be doing?
You have just noted it as something that we need to follow up on. Again, thank you so much, Lucy, and we will send you an email.
Okay, great.
That is what you did. You reminded us.
You've been a little busy. I just didn't want it to get lost. Thank you.
I would admit that although I might be an ideas person, following up on things is sometimes I need assistance. So
that's why I asked if there's something else you'd like me to do, but I'm waiting for your email. Thank you.
Can you send the links in the chat? Links to the links to the Confluence here. Yeah, so when a Gravity team, can we put the links to the Connect-a-thon signups in the chat for Deb?
Ma'am.
Thank you.
No problem. Give me just a minute.
Thank you. And that next slide, please. I think that we might be, oh, there we go. Thank you for participating in this national consensus building process. If you have any questions, again, this is the best email to send things that need to be followed up onto, gravityproject@emiadvisors.net. Where are the results of the last Connectathon posted? Lynette, Evelyn's not on the call. I honestly don't.
I am searching for the link as we speak, so please hold.
Lynette's on all of it.
Yes, let me,
Okay.
actually, I have an easier way to do this. Hang on. All right. Give me just a second here.
There is an element on the confluence is a confluence for both elements of work, though, right? So the domain work is contained under the different domain sections, and the fire work is contained, it's right above it on the left-hand side of the confluence sidebar. Any other questions while Lynette does the amazing things that Lynette does? So suffice to say, email me again if you have any other further ideas about connecting with the community. You'll see the ICD suggestions go on to the master to be part of our work. And then, oh, here we go. May Connectathon report out. Thank you.
And I'll send the sign up link in just a second when I get to the other end of the PowerPoint. Just a second.
All right. So any other questions before we go? I can't believe we have time. This is unheard of. Thank you all. So those of you, oh, there it is. So there's the Connectathon sign up link. There's the May Connectathon results. And Jim gave very nice feedback. Thank you. And we look forward to seeing you on the 11th. Again, there was that ping for possible weekly meetings. I think I really just want to make sure that you all are aware that we are assessing that requirement as we go forward, because we want to make sure that we complete this in a timely fashion. So if work groups on the side are not addressing the needs of the labor, we might leverage that weekly meeting and keep on going, okay? Thank you all. You have a lovely Thursday evening, and I will see you in a couple weeks.